We're live. Welcome, folks. This is a joint meeting of House Healthcare Committee as well as House Corrections and Institutions Committee. We had a joint meeting a long time ago, which was the first week of the session.
Yeah. Seems like a long time ago.
Feels like 4 months ago,
Yeah.
not 4 weeks ago. We're going to continue that meeting. We had scheduled at that previous meeting to hear from our contractor who provides healthcare services in our correctional system, our correctional facilities here in Vermont, WellPAT. It's the entity we contract out. They were on Zoom and waiting for us, and we just didn't have the time because we spent the bulk of our time talking with DOC for folks to get an understanding of how healthcare services are delivered within a correctional setting, which is a little different out in the community. So we've scheduled today to hear from the contractor that the state contracts with. And we're going to start with Max Titus, who's the Director of Health and Wellness for the Department of Corrections. And we have Jessica Sherman, who is here, who's the Regional Vice President of WellPAT. And I don't know if you both want to come up at the same time. How do you want to do this?
It doesn't matter. I was in chair first.
Okay. Okay. Why don't you come on up? That table seems so
I know.
far away.
My glasses.
I know.
Max.
So, man,
Sorry, we're so far away.
are you okay down there?
The chair, okay?
Yeah. Yeah, it's fine.
So if you could introduce yourself, Max, and give us just what your role is and also how DOC enters into a contract, what the process is, because we have a bidding process, and how long the contract is for, the cost, and what is covered.
Okay. Yeah, Max Titus. I'm the Director of Health and Wellness for the Department of Corrections. I can start with a broad overview and then zoom in or answer questions as needed. So as you know, our current model for providing healthcare in corrections is through a contract with an outside vendor. Our current vendor is WellPath. We are in our 7th month with our contract currently that started in July of last year. And there is an extensive process that we go through so that the contract was about 18 months into our process of getting a new vendor. And so that planning process started early in 2022. That process essentially starts with us looking at our current model, looking at the system that we have, looking at the resources and determining if any of the alternatives out there are something we want to pursue. For example, some states and some jurisdictions do a contract model like we do. Some employ state staff that provide the direct care. Some partner with outside systems to come in and provide the care. And some do a combination of all of those things. So at that time in January of 2022, the department decided to move forward with our current model, which was to go out to bid for a new contract, knowing that we were planning for 18 months in the future. So our team essentially spent a ton of time with our RFP to make sure that it included the expectations of what we were looking for in our system. We view it as our team at DOC builds and sets the expectation of what the system will look like, and the vendor is implementing and providing the care as part of that system. So we released the RFP in mid-2022. We received 2 bids, both from private or for-profit healthcare companies that specialize or specifically provide healthcare in correctional settings. Based on a lengthy review of both vendors' materials, we did interviews of both vendors, did research, media and legal histories on both. We determined that WellPath was the year we were going to move forward with contract negotiations. And then we engaged in the discussion about the details of the scope of the contract, the financial provisions, and any conversations about state language that's included in all of the contract. So that process concludes with an agreement between both parties of what we anticipate the contract to look like. And then from there, there's a state review process where it goes through various state agencies for approval. The intent is that the contract started on July 1st, which it did. A lengthy transition period work that goes into that actual takeover that happens 90 days and further in advance of the contract itself. So we consider that pre-90 days plus the first 3 to 6 months of any contract as transitionary. A new vendor is really coming on. They're onboarding and training staff. They're recruiting for vacant positions. They're learning the system. They're learning how we do things in corrections in Vermont, and then they're assessing what needs to be done to improve the system or to bring it to the contract expectations that we have of them. So that brings us about to where we're at now, which is we've just sort of shifted into an onboarding phase with WellPath, and we've been focusing on a change management plan, which is a requirement of their contract. Essentially, they spent the first 6 months assessing the current system by contract requirement and determining where in our system we are meeting those expectations already or what changes may need to happen for us to get there to achieve essentially our desired state of health system. So that brings us to essentially where we're at and covers the bid process and the contract negotiation process. And I'm happy to talk a little bit about the specific contract structure and then answer some of the questions that were posed in the last testimony about the financial provisions that you guys didn't get into. Do you want me to pause for?
And before you go there, I know we have a question from a member. John?
When you review an the bids, when the two come in, do you keep the price concealed until you've reviewed all their aspects and then look at the price last?
So we predetermine criteria for scoring of the materials that are presented as part of their proposal. We don't keep the price confidential until after, but it's scored separately. And our financial director is a part of that conversation as well. Essentially, we have a team of individuals that come from mostly the health services team at DOC, plus some operational folks, financial folks, and folks in different divisions that come together, review all of the content of the proposal, essentially all the services that the vendors are proposing to provide to meet our requirements. And then we have a separate conversation about the financial aspects, which factors into the decision. And then we have another conversation about the IT components, which is they bring their own network to our facilities. So there's an ADS component too.
Did WellPath appear to have the lowest price?
That's a good question. The cost in this, I don't remember the exact numbers. The cost for the two bidders that we got in this last bid was very similar. It's very close.
All right, and then Mary, and then we'll continue with your testimony.
Thank you. This is coming from nurse, healthcare worker. What standards does the Department of Corrections and or WellPath use? What model of care do you follow? Do you follow national standards like the National Commission on Correctional Health? And did you use a minimum standard of care for correctional health care to evaluate WellPath and to continue to assess quality and safety in an ongoing way?
Yes. And actually, I was going to speak to that, but I'll just go into it now. So that's good. So our contract is structured around the National Commission on Correctional Healthcare Standards. It's a requirement of WellPath to ensure that all of our facilities are accredited. And we have been accredited for many years through multiple contract terms. That is a baseline, what we consider like a minimum standard of care. And we actually, in our contract, although it's structured in the same title format as NCCHD standards, within each of those, we include Vermont-specific requirements that go above and beyond the NCCHD standard. And then we have an additional section at the front of the contract at the beginning that goes into any Vermont-specific requirements that aren't already included, including minimum staffing levels in certain areas, human resource requirements, et cetera.
Is that something you could share with us?
Sure, the contract, you mean?
Yeah, in electronically.
Can you make a note?
So we have one more question, Mary, and then the other two.
And
So the bid on this, what highlighted WellPath as being getting the contract? Were there certain services they could provide that the other couldn't, or how did that come about?
That's a good question. So obviously I mentioned we had a scoring process with predetermined criteria that was specific to the actual bid materials and what the vendors were able to provide. In that case, it was relatively similar between the two parties. So we really relied heavily on the interview process with the vendor. One of the things that was really important to us as a health services monitoring team was making sure it was really clear what our philosophy was about the care that's provided within our facilities. There's this term, it's commonly called correctional healthcare. And we actually were upfront and talked in our interviews with our vendors about, or with the bidders about our philosophy that we are not providing quote unquote correctional healthcare. We're providing healthcare that happens to be in a correctional facility. And that was the core value of our discussion with the bidders was about philosophy and whether the philosophy of the vendor aligned with what we're looking to do. So I would say that was the primary difference.
so when you went through this process, does the wellness team or whatever your team is called work with VDH, Department of Health, Department of Mental Health, DEVA, the other agencies within Agency of Human Services that provide and monitor and do insurance for healthcare? Is there a collaboration there at all? Or are they involved at all in the process of selecting a vendor or monitoring and providing oversight of the vendor?
Yes, good questions. So they are involved in I would say in general, they're involved in our day-to-day work. We work with the other departments within AHS frequently. For example, it's a requirement that the vendor have a drug formulary that's as closely aligned with the Medicaid preferred drug list. So we are working with the other departments to determine what is the community standard. How do we build that into our contract language to make it clear? During that process, during bid process, we typically try and include a representative from another department and other divisions to have that voice there. And if they're not included in the specific scoring aspects, they're consulted as part of the process.
Great, thank you. You know what, we're gonna hold, so write it down. We're gonna let Max
Okay, I'm
continue.
going to continue on because I also realized I didn't answer the CQI portion of your question, so I was going to talk about that anyway. So there is an additional section of the contract that is devoted to how we as a monitoring team oversee the services that are provided and then how we're able to follow up with the vendor to make changes and impact that change process. So WellPath, as any healthcare entity, has their own CQI process, and I'll let Dr. Sherman talk more about that. But we require that our team is a part of that process along with them, and that we are able to bring to that discussion any areas of concern that we have. The contract requires us to have a monthly meeting and a committee, and there's a whole process outlined about how that happens. And the contract also ties liquidated damages, which I'll talk about when I get to the financial more. So essentially, we can withhold funds if the contractor is not engaging in that process with us, as it's outlined in the contract.
Max, I think it would be important to talk about what the cost of the contract is.
Sure, yeah, I can.
Give us the dollar amount that we pay for it.
So to specifically answer that question, there's two answers. There's a per individual per month rate that we look to, but essentially it comes out for year one, around 34.7 million is the total contract budget. And then for year two, it's 38.1 million, and for year three, it's 40.6 million. And that is based upon during the contract negotiations process, the vendor brings a budget with their proposal of what they propose it will cost to provide the services that we're requesting. That budget is broken down by sections that include everything from staff cost and benefits to pens and pencils. It's broken down and itemized in the way that you would anticipate like a healthcare organization. And so that PIPM is determined during the negotiation process. And we refer to it frequently, but and I want to be clear, it's the basis of the negotiated amount that is paid to the vendor. Once it is signed and the contract is done, that per individual per month rate does not change based on the daily fluctuations that we have with the number of individuals. So during the negotiations, we determined an estimated in-state population would be 1250, and that's how we calculate that PIPM times 1250 is how we get the amount that we pay WellPAP on a monthly basis. It is the same amount each month, and it's been determined. It doesn't vary unless we go outside of a range of average daily population, and then we would renegotiate that.
Can you tell us what the rate is?
So yeah, for year one, it's 2,253 and 33 cents. For year two, and this would be in the document I share, by the way. So it's $2,476.81. And for year three, it's $2,636.74.
Great. Question.
Wayne?
So those are pretty substantial increases from year to year. What's driving that?
So that's part of the proposed budget. The cost of healthcare continues to rise. The cost of staff, and the reliance on agency staff when we don't have full-time staff, has increased over the years. So we add into that budget. I guess we don't, WellPAP does, but then we can, talk about that during the negotiations. An amount that seems reasonable for what they anticipate the cost of supplies and staff and other increases from year to year.
Seems pretty substantial increase that's projected out into the future. And
Yeah,
you're
it
locked
is projected.
and you're locked into a contract with that.
We are, and we have terms that allow us to renegotiate if there's a substantial change in either the service or the conditions of the system.
And can I just follow up? And if the cost is more?
Yes, let me talk about that.
Yeah,
So-
and then we'll go to Art for your question.
We oftentimes, and I think this came up in the last testimony when my colleague was here, get questions or comments about contracting with a for-profit vendor. The question tends to come up of how would that, or would it impact care, and if so, how? So our team has the considerations when we look at the vendor and the cost model. And so for the last several contracts, we have included language to try and address that issue and to make sure that providing less care does not incentivize additional funding for the vendor. So our contract requires that pre-agreed upon budget and a year-end reconciliation every contract year. At the end of each contract year, WellPAP has to provide their actuals broken down and compared and mapped to the budget that was originally agreed upon. If their actuals are less than the budgeted amount for that contract year, the difference is returned to the state and it becomes state funds again. It's used at our discretions. If at the end of that contract year, we actually have spent more in actuals than what the contract was budgeted, there's language that requires like a shared risk. The first 3% of the overage is paid for by WellPath. The second 3%, so 4 to 6%, is paid for by the state. And if we're over 6% over our budget amount, we negotiate based on the circumstance. So essentially, if WellPath provided less care and didn't spend as much money on it, they don't keep the money, it comes back to the state.
Has that ever happened?
Yes.
Could you
The
read-
question was, has that ever happened? Not in this contract or the last one, but in previous contracts. There were times where savings were returned to the state.
All right, go ahead.
Yeah, when a contractor like Wellcat comes in, you know, they came in lock, stock and barrel, I guess, to do this work. Do they bring equipment with them, supplies, or do we provide everything that they need to do the work? Or is it just people?
It's not just people. So we obviously provide the space, and we provide equipment to the extent, like the beds, for example, DOC pays for the bed. So in infirmaries, when there's a hospital bed, DOC purchases those. We provide anything that's property of the state. WellPath does bring in office furniture and specific medical equipment that they may subcontract with for vendor to provide on site. And Dr. Sherman can speak to the details of what other equipment they bring in, but they also are bringing in an IT network. So even though they're working in our facilities, they're not using the state's network. They bring their own IT network into the facilities. Their staff are working on their own network. So there's an ADS component to it. They're bringing obviously staff, and they're also bringing like subcontract services that might come in as well.
And how about like personal gear, all the personal gear is
Yep.
there?
All of the medical supplies, medications, anything that's needed for the actual provision of care.
Is theirs
Yes.
provide?
Yeah.
Okay. All right. Thank you.
So we have another question, John?
With our contract down in Tallahatchie, does that include healthcare or does WellPath play a role down in Mississippi?
The contract with WellPath is just in state. The contract out of state, which is not my area of expertise, does include the healthcare portion of the folks that are out of state.
Do you have much more? Or are you?
I have a couple more financial things I wanted to mention just about the contract. So we also include, I might have mentioned liquidated damages as part of our CQI process. Essentially, that is a predetermined and agreed upon rate that our team can deduct from any invoice when we have determined that the contractor is not fulfilling the terms of the contract and not engaging in the process to improve. Those liquidated damages are deducted and cannot be recouped at a later time. So if we deduct from the invoice, the WellPath doesn't have the opportunity to earn it back. We also have holdbacks, which we can use anytime we haven't received all of the documentation or information we need to verify that WellPath has complied with the contract. We can hold 5% back from each invoice. On the flip side, we also have payment incentives for a certain performance. So we have a list of performance metrics that, depending on the threshold of performance by WellPath on each of those metrics, they can earn an additional 3% on top of what we have determined as the year budget. And so those are calculated on a monthly basis and added to the contract when funds are released. So I think those are important aspects, and we can talk more about that if you want, but just wanted you to be aware. I think generally I'd just say, when we're looking at the system in corrections, it's important to consider it in context with the larger health system in Vermont. We're just a part of a larger health system. And what we often see in corrections, as Commissioners Stimmel and Levine noted last year in their op-ed, mirrors and magnifies the challenges that are seen in the community. We are seeing generally an older and sicker population, people that have a lot of health needs and are challenging to care for. And so I think that's important to consider. I have some stats on, percentages with chronic illnesses, the percentage on MAT, things like that, if you want me to speak to it, but I know you have time.
We have a lot more questions here. So
Okay.
we have Mary and Chip and Tristan. Michelle, I thought it was Leslie. Okay, and Connor. Okay, I saw a hand over there. Mary?
My question was somewhat answered.
Oh.
Okay, Chip?
Thank you. So I think you characterized the process as a negotiation with WellPath in order to forward the process here. My question is is there a vetting process as well as a negotiation, or is that part of a negotiation? Is there a separate vetting process? And how might that work?
Can you say what you mean by vetting process?
Well, I guess look into the practices and history of the potential provider and see if you can recognize anything good or bad about their practices and history,
Yeah.
that sort of thing.
Okay. Yeah, so the negotiation process is strictly after we've made a decision to move forward, and the vetting process happens prior to that during the bid review process. So once we've reviewed the materials, interviewed the vendors, had internal discussions, we do reference checks. So the vendors providing references to us. We also do other background and research, and I can defer to Isaac, who I think was involved in that process, to look into, media history, legal history. All of those things are required as part of the bid submission for the vendor to provide us their litigation history and essentially that information. And then we do our own checks of that as well. That happens before the negotiations. Then when we make our decision, then we shift into negotiations where we're talking one-on-one with the vendor about the terms of the contract.
Does the provider have to be licensed in Vermont in order to obtain this contract?
So the contract is really comprehensive services. Each individual who is providing service under that contract is licensed just like any community provider would be. So the medical providers are licensed medical providers in Vermont. Nurses are registered nurses.
Good. Thank you.
Tristan, Michelle, and Connor.
Thank you. It seems to me that there's some reassurance that there's an incentive, there's not incentive to withhold healthcare. It is the intention of the contract. That seems clear. It doesn't seem clear that there's an incentive to get people healthier or, and if you looked at performance-based ways of actually asking to, given the many challenges of the population the DOC is serving, WellPath is serving, to look at population measures like hypertension, diabetes, and try to rein those numbers in or get people healthier.
Yeah, it's a good question. So I mentioned very briefly the pay for performance metrics. So we have a predetermined list of metrics, which are a combination of things that are interest of our monitoring team, as well as metrics that were originated through like HEDIS measures, which is like a well-known hospital metrics. And then we've also consult with our VDH or DIVA partners to talk about metrics that might make sense as well. So that is incentive dollars, which is intended to be that if the vendor achieves certain outcomes beyond what's required by the contract, then they are getting additional funding.
How much?
It's up to 3% of the total contract.
Thanks.
Michelle and then Connor.
Yeah, so my
And
question.
then we're gonna go to WellPath, so we make sure we get to them today.
My question is related to that as well. Actually, you talked about liquidated damages and incentives, and I'm wondering, so it's actually two questions. The first part is, how often is that calculated? Do you look quarterly? Do you look annually? How long do you take to look at potential damages or incentives and then figure that things are either going well or not? So that's the first question. The second question is, could you give some examples of what that looks like? Are we talking about, fewer heart attacks over a long period, or just if you could give some examples of what would qualify as an incentive, and also particularly what would qualify as when damages would happen, because that feels like a useful thing for us to know.
Sure, yeah. So they're calculated monthly because they're tied to each monthly invoice. And I mentioned, I think briefly, but it's worth noting that liquidated damage is essentially a rate based on the amount of time that the actual amount of time it takes our team to resolve whatever issue it is that we have. So if our team collectively spends 10 hours in a month to resolve an issue that we're not getting what we need from the vendor, then we would say 10 hours times that pre-negotiated amount, which I don't have off the top of my head. And then that would be deducted from the invoice that month. So that's how it works.
So it's just based on how much time they take to address an issue, not what the outcome is of the issue.
That's how much time our team has to spend to resolve the issue. So essentially it's like if we've assigned a timeline and they don't meet the timeline, and it takes our team 4 hours of conversations and following up or whatever to get the resolution that we need, then we charge 4 hours times our rate.
And then what about the incentives?
And on the incentive, I don't want to quote the specifics, but we have the metrics that we could provide the description and numerator denominator for you.
But is it also about time or are there?
Some of them are based on the threshold of meeting timelines that we've expected. Some of them are about discharge planning and the percentage of individuals that are receiving certain elements of discharge planning at release. There's, I think, 26 metrics.
Connor and then John.
Thanks very much, Max. A lot of my questions you answered already with some of the guardrails in the contract. And I'm just kind of trying to balance in my mind, like what's realistic versus what's acceptable, right? And in my mind, having like a private equity firm care for people in our custody, still subject to like bottom line objectives and shareholders. I just don't like it, it sits wrong with me. But realistically, I've seen the cost models, right, of how much it would cost to bring in-house. I know that like prison healthcare doesn't get great press generally, no matter who's providing it. But at the same time, we're the oversight committee, right? And it's a gnarly Google search, WellPath. It is. It's, somebody at Springfield whose license has been like suspended in 3 states. It's inmates getting the wrong medicine. And it's tough, I think, when constituents call because it feels like there's a level of detachment, when it's a private contract versus more in-house work where it could be more accountable, more oversight to it. So I guess the question is like, I'm looking at the cost analysis and it has 204 full-time positions for state employees. The first question would be, do we have 204 WellPath employees on the ground right now? And then you kind of mentioned like looking at other models. And I think it's interesting because like the state hospital, the state employees do work, but they partner with a tertiary hospital who's providing some of the functions at the top end there. So like, have you considered those models? I wonder like, if you ask Fletcher Allen, hey, here's $40 million. Could we work out a deal or something? Would that be a conversation starter? Designated agencies with mental health. So I'm just wondering like, so going forward, like, it might be acceptable now, but long-term, do we want to move in another direction?
Yeah, no, I mean, I think I understand your question to be like, how have we considered other models in the past? And to what extent? So I'll say I mentioned before in the bid process, that's always the first step before we decide to go through that process. It takes a lot of time and effort. We consider it. And each time we go through that bid process, and then sometimes in addition to that, we do have these conversations. I think the last time, I'm looking to Isaac to make sure I get the number right, but the last time we did an estimate of what it would cost to do it strictly in-state, the number was more than double what our annual contract with WellPath is now. I think it was upwards of 80 million. And that is based on all the things that go into employing state staff versus a private entity employing staff, the ability for vendors to get negotiated rates that are lower than what we may be able to get because they're doing large, like national scale business, things like that. We do consider that. We consider partnerships. The challenge is we experience the same challenges that the community system does with staffing and being able to hire and retain staff. WellPath has a lot of resources in recruitment and being able to hire and onboard staff in ways that would be challenging, I think, for the in-state to do based on the resources that we have here. So I think there are some operational challenges that we consider as part of it as well. We have approached community health systems and providers and had some of those conversations about the DA's EBM health system, for example. And none of those conversations have ever resulted in the outside entity wanting to be a partner of ours. And so I think once we do get into detailed conversation, people start to understand how complicated it is, and how complex it is and difficult it is to hire and retain staff and to provide service at this level.
Thanks.
John?
I'll follow up on Representative Oslin's question on liquidated damages. When you mentioned it, my mind immediately went to, okay, well, for an example, a diabetic gets a foot infection, it's not treated properly, and it results in hospitalization or worse. From your description, it didn't sound like that was part of the equation.
Yeah, it could be. So if we had heard of that and identified based on it that there was a deficiency in care provided, that was an issue of the vendors, we would engage them in that CQI process that's outlined in the contract. Essentially, it allows our team to gather as much information as we need to really evaluate the issue, and then designate that we've identified a deficiency that needs to be resolved with a plan. If WellPath is agreeable and makes the changes necessary, we would not engage liquidated damages. However, if we don't get the response or the change in practice that we're looking for within the timelines that have been set, then we would engage the liquidated damages for that.
Okay, thank you.
Great. Max, when you send the contract, and which I'm assuming is where the metrics are that you've talked about, if you can point those out, and if you could also include any results to date that you've had with WellPath, so we can just see what has been and what the oversight is, that would be great. Thank you for your testimony.
Sure. Thank you.
Ready? Jessica, why don't you come on up into the hot seat, which has been warmed up. Welcome. Yes, and if you could identify yourself for the record. And you've also heard some of the focus of some of the questions, but we'd also like to hear in terms of how WellPath sees delivery of services within a healthcare situation. Maybe also explain a day-to-day operation of what occurs in a facility with your medical staff, what they encounter, what they see coming in for services, how it gets resolved, how it doesn't get resolved. That might be helpful for the committee to have a perspective of what's occurring within our facilities.
Yeah, of course. My name is Dr. Jessica Sherman. I'm the Regional Vice President for the WellPath contract here in Vermont. Our services, we provide comprehensive medical and dental and psychiatry, behavioral health, nursing. We contract with audiologists, ophthalmologists. We provide physical therapy, radiology, just about any kind of service we can provide on site, we will do so. If we are unable to provide that service on site, we contract with community providers to set them up with, say, a specialty care like a cardiologist or endocrine, and then we will follow that plan of care that provider had set forth for us. Each site has a medical clinic. So just kind of give you an overview of how each site is run. Each site has their own leadership. They have what's called a health service administrator. That person is the administrative oversight of the clinic. They have a licensure. They may have a licensure or certification in healthcare, but they may also have a degree in healthcare management. Most of our HSAs are nurses, although they don't have to be nurses to be in that role. The HSA is the administrative oversight, so they are the liaison for that site between the medical department and their site DOC. So they meet daily with the superintendent and other members of the DOC on that site to review medical cases that they need to know about, like if somebody is going out for an appointment or maybe there's somebody in the hospital. They would give updates on, when they're planning on coming back. Maybe they have a patient in the infirmary. Details about when they could be released and go back into their housing unit. The HSA also provides just overall ensuring that the day-to-day for the staff on site is that they can do their job. So providing that support and ensuring that supplies are ordered, ensuring that their staff is supported in getting medications ordered. They also do a lot of like peopling. So if there's conflict between staff, then they would help resolve that. Next in line after the HSA, so everybody on the site ultimately reports to that HSA. Next is the director of nursing. Each site has a director of nursing. They're the clinical oversight of the nurses. They focus on orientation, training. They also focus on patient care. They help us with our CQI processes and making sure that it's getting to the frontline staff. So it's not just a meeting that Max and I have. It gets to the HSA and it gets to the DON to be able to implement at the staff level. They also are clinical, so they may fill in for some of the vacant shifts if necessary. They also, are able to resolve conflict amongst team members. They see patients themselves. We also have what's called a health service coordinator. Most of our health service coordinators are LNAs, although you don't have to be an LNA. They are busy usually scheduling outside appointments for our incarcerated individuals. So they take what is given to them from our providers and they put it into our utilization management system for referral and approval. And then they set up the appointments for the incarcerated individuals who go out and have their appointment. They also help with discharge planning. They can be clinical if they're an LNA and help on the floor. They also, I kind of refer to them as the glue that keeps everybody together, because they are the ones that kind of also help order the supplies and whatnot to make sure that we're have everything we need to be able to do our things. We have nursing, we have medical providers, we have psychiatry, we have mental health at every facility. We have dental chairs at 4 of the 6 facilities, and the 2 facilities that don't have dental chairs, they have transports twice a month to what I like to call is their sister site. So Marble Valley and Rutland goes to Springfield, and Northeast and St. Johnsbury goes to Newport. Day to day, meds are a large part of what our nursing staff does. We deliver about 10,000 medications, 10,000 pills a day in the state to our incarcerated population. So we have nurses that are dedicated to Medline. They have specific times of the day that we do Medline at each site. It's based on working with the security side is why every site might not have the same times. It's based on security flow. So we provide meds. The nurses also do what's called sick call. So if a incarcerated individual has an acute complaint, they are able to put in what we call is a sick slip. The sick slip is entered into a centralized location within their dorm, and then a nurse comes around and picks them up at midnight. They read them and triage them if it's an urgent thing. Like sometimes people actually put on sick slips, I have chest pain. So in the middle of the night, they will go to that individual and assess their chest pain. But if it's something as, I have a hangnail, I have back pain, I want to be seen by the provider, those things are triaged and the nurse will see them face to face within 24 hours of receipt of that sick call. They will use the WellPath nursing guidelines to take care of that patient up to the scope of their practice. And then if they are unable to treat them based on their scope, then they would be referred to the on-site provider. Nurses are also very involved in site level on wound care, treatments. They do like nebulizer treatments. They're also in our booking area where the intakes come in. They do that medical intake that spoke about, that is very lengthy process. They'll do that medical intake. They're also out there with our patients that are coming in and out for if we have people that come in that are actively detoxing or, there for a short period to sober up, they are monitoring those patients as well. We have, for medical providers, we have majority mid-level providers. So we have nurse practitioners and physician's assistants. We do have a doctor coming down to Southern in a couple months. Once that doctor arrives, we'll be fully staffed with providers. The providers day to day, the nursing staff will set them up with a list of patients to see based when they were seen last, basically. So the providers are doing what's called an initial health and physical. That has to be done within 7 days of being admitted into the incarcerated setting. After that, their annual health or periodic health and physical is based on their age. So the older you are, the more frequently we're going to see you. So you might be every year, you might be every 2 years, every 3 years based on your age. We also have what's called a CIC, which is a chronic care visit. That is, we've determined in your initial H&P, we realize that you have maybe diabetes or heart disease. We're going to have you have an initial chronic care visit at that time. And then we're going to manage your chronic care condition. They typically, in the beginning, might see them more frequently, but it's usually a 30, 60, or 90-day rotation. Once you're stable with that chronic condition, they would put them on the 90-day rotation. So they're seeing those patients, and then we're popping in those sick calls throughout the day as well. If everything is moving, as if we're working with our Department of Corrections counterparts. So as long as patient movement isn't altered, our providers can see anywhere from 15 to 20 individuals a day. We also have dental. Dental follows the same process with initial and periodic reviews, assessments, and sick call. There's dental sick call. They have to be seen by a dental provider within 30 days of admission into the incarcerated setting. Typically during the initial health and physical, or the nurse seeing them upon medical intake, they will do an oral exam to see if there's anything that would require them to be seen quicker. We have psychiatry at all of our sites. Our psychiatric providers are nurse practitioners. We use remote psychiatry for majority of our facilities. We do have 2 facilities where the provider comes in person at least once or twice a week. But our psychiatry is done remotely. We do have folks who will set up the telepsych for the individual, and they call them up, they set them up, they wait for them to be done, and then they bring the next person up. Mental health is, they have also parameters that we follow based on NCCHC guidelines. Once somebody comes into the facility, they have to be seen within 7 days. Once they're put on the mental health list, they also have those periodic reviews that could go 30, 60, 90 days. Same with psychiatry based on their med requirements.
You want to stop? I do think we have a couple questions. So we're going to start with Art and Mari, Melanie, and then Connor and Daisy
And me.
and Leslie.
I guess I'm first. How many overall visits do you see, I guess, let's say in a month or a year? I mean, how many interactions with patients that are sick or have if you check somebody in when they first get there, I get that. But how many times are people going to the infirmary? I mean, do you have data on that, or maybe you don't know?
Well, the infirmary is different than our medical suite. So we have like a clinic, like a primary care clinic,
Oh, you
basically.
do?
So we act as like a primary care, urgent care in our clinic. And then Southern, Northern, and Chittenden have an infirmary, which is for a higher level of care.
Okay, so a clinic, every facility has a clinic,
Every facility has a clinic.
but every facility doesn't have an infirmary?
No, if we have an individual that got healthcare needs that would be not hospital level care, but they aren't able to care for them in their current facility because they need infirmary level care. The DOC transfers them typically to Southern State. Because they have 9,
infirmary.
yeah, to an infirmary.
Okay, so I guess my question would be, how many visits to clinics do we see in the course of a year, a month, or some indices so we get an idea of volume?
We do have that data on that.
Yeah, you figure it out. It has to be today. I just wanted to get a sense
Right.
of what we're talking about here.
MAT.
Yeah.
Just to give an idea of context. Sorry, the monthly average sick calls is about 3,400 sick calls across the state.
How many?
Did you say 3,400?
Yes.
3,400.
Monthly,
And the average monthly number of provider visits is over 1,000. A little over 1,000
Per month.
per month.
Per month.
What was that last one?
System.
Provider visits. So,
Okay, what's that mean?
so provider is medical. Is that where, are you just counting medical? So medical provider visits.
Okay, so you got 3,400 going to the clinic. And then beyond that, you've got 1,000.
That are being seen by the provider for their H&P or their chronic care visit.
Okay,
Is that 1,000 part of the 3,400
No, that's
separate?
That's what, yeah, that's the sick calls I meant.
visits.
And-
Sick calls are counted.
And that is not unique individuals. That could be one person coming in 10 times.
Yes.
yeah.
Right?
hi, good to see you.
Good to see you.
Colleagues in the past.
Back in the day.
Yeah.
Fletcher Allen was called Fletcher Allen.
I have two questions. First one is remind me who does the triage when there's a slip,
The nurse. A nurse.
a registered nurse?
A registered nurse or an LPN.
Or an LPN.
LPN is doing the triage and the call, and RN has to sign off on it.
Okay. And does WellPath provide, or do any of the facilities have point of care testing like EKGs when someone's having chest pain, diagnostic imaging, ultrasound, things that can be transmitted for interpretation by a qualified provider, and lab sampling, for example,
Yes,
therapeutic
so-
medication levels?
Yeah, we do phlebotomy on site and we send labs out. The labs come back and our providers will, interpret
Interpret
the
them.
results. We do have, radiology that comes in to the sites when there is a need. And then there is a, part of that service is somebody that reads and interprets that. And the provider can also read that.
EKGs as well,
EKGs, we have, an EKG machine in every clinic.
and a qualified provider can read that immediately okay. And then can you give us an update on the progress you're making around the hepatitis C issue?
Can you be more specific?
So there was a case, and I don't know if you want to dive into this one. I'm sorry to put you on the spot, Jess, but there was an issue with hepatitis C levels.
I think you might be referring to a settlement agreement that was in place related
Yes.
to this. Actually, that agreement has ended. I think we're closing out our reporting for that agreement. Our policy is the same as what was agreed upon that, which I think was in 2021. Hasn't changed. The challenge with treatment for fatigue is really around the determining someone's length of stay and the amount of time that's with us for us to be able to do the workup to determine the treatment that's appropriate. And then provide the 8 to 12 weeks of actual medication and then monitor afterwards. So our policy addresses how we factor in known length of stay into clinical decisions. And then there's specifics in the policy around folks that are treated regardless of length of stay that meet certain clinical thresholds of disease. So our policy is unchanged. Our monitoring has continued since.
The screening,
Yep. If it's screen positive, they're like any other CIC process, they're followed by the health provider. The additional lab work and workup that's needed to determine treatment occurs, and there's a review month to month, which is part of our policy of stay and how that may impact the treatment.
and I did receive, well, shortly after I asked for the contract, so I appreciate, that was sent along with a bunch of other documents, so thank you.
Melanie?
I believe I heard you saying that health service coordinators within the hospital or within the corrections facility sometimes outsource to other specialists or sister sites. I'm wondering how many times that happens, and is the billing for that?
Melanie, can you speak up a little bit?
Yeah, sorry, is the billing done for that through the negotiated contract, or is that another, all the, and providers get great spelling, how much they get of that, their reimbursement?
I can't speak to the reimbursement,
Yeah.
but so we use outside community providers for specialty services.
And there's data on how many times we have,
I can get it. It would be in our utilization management system, but we do send our incarcerated individuals out for specialty service quite often.
And then you spoke about psychiatry being done remotely and on telehealth. I'm curious if there is any in-person counseling, if you could speak to what happens for mental health care in the facility.
Again, Melanie, we need you to speak up.
Sorry.
Yeah, sorry, it's a really long table.
Yeah, you spoke about psychiatry being done remotely and like telehealth counseling, and I'm just wondering if you could speak to what is done within the facility, person to person. for mental
Yes,
health
so we
care.
do have mental health, licensed mental health clinicians on site. We also have rostered as well, whose oversight is from the licensed folks. So each site has mental health counselors. They do one-on-one sessions with individuals and they do groups.
All right, so I have Connor, Daisy, Leslie, Wayne, Tristan, and then we're gonna go to Vermont Department of Health. Connor.
Thanks, Doctor. No worries if you don't have it on you. Was hoping you could just maybe provide the committee with some of the staffing numbers, total staff on the ground, administrative versus medical, who's doing telework, how many of Vermonters would be interested? And then I was wondering, it's a tough gig, right? Like, we have trouble recruiting COs and we have trouble recruiting healthcare workers. So having somebody provide healthcare in a facility, that's a heavy lift, right? What are some of the strategies for recruitment that you use?
So WellPath does have a robust recruitment team. And I would just like to say that, we work for WellPath, but we're all Vermonters. So we're all people, we didn't come from some secret WellPath thing. We are all Vermonters. So, I'm born and raised here. So we're all Vermonters. We do reach out, for the sites that are closer to the borders. We do stretch our recruitment strategies out to New Hampshire, into New York. We have even for Newport started trying to recruit up in Canada. And can't remember the town right above that. So we have when we first started the contract, we had 4 recruiters dedicated to Vermont from WellPath. In that time, when we transitioned from VitalCore to WellPath on July 1, we had significant agency usage, travel nurse usage. Especially in Newport and in Southern State and Northwest. And Chittenden. So 4 of the 6 sites had substantial use of agency use. Since their recruitment model has come in, we have been able to, we no longer have agency usage at Chittenden in the women's facility. We are close. We have about 4 FTEs, 3 FTEs left at Northwest for nursing to replace agency with. About 4 at Northern as well, and Southern, we have, we were about 80% agency when we switched over. I would say we're probably down to about 60% now, at Southern. Recruitment strategies that they have been using, when we, try to convert agency staff members that have been here for a long time. Some of the agency that have been working with corrections have been working with corrections in Vermont for years. So getting them to convert to WellPass and we've been successful with a handful of agency staff that have decided to convert to WellPass. We also, go to students in the nursing programs. So we try to get clinical
Placements.
yes, clinical placements, thank you, with nursing students, nurse practitioner students, so that we can recruit from that as well, because that's really where you need to start. They've been doing a lot better job of reaching out to people. They've been doing a better job of, making sure that those posts are on Indeed. And they've been also, our recruitment has also been helping with trying to support the on-site leadership in tactics with interviewing and making sure that we have the right bodies in the right seats.
Doctor?
Thank you. Daisy?
I apologize. I'll try to be quick. Melanie kind of got at a bit of my question around psychiatry and portion of it being via telehealth versus in person. So I'll try to focus on my questions around quality, access, and outcome standards. Given that the general population is approximately 18% of us have been diagnosed with mental illnesses versus I've seen statistics as high as 45 to 50% of the incarcerated population being diagnosed with mental illnesses. What can you say about what WellPath is doing to maintain, I guess, parity with the standards of access, quality, and outcomes that we have here in the general population come to expect from our mental health providers? What can we do to maintain that for people who are in the justice system?
Yeah, we do, so we have mental health clinicians at each site, physically on site, who see patients one-on-one. We do a lot of groups that and we follow curriculum that is approved by Annie at the DOC. So we follow that curriculum when we do groups and one-on-one counseling. We do have at least each site has, depending on the number of folks within that facility, they have a matrix based on what they need for mental health. We have been recruiting mental health just as heavily as we've been trying to recruit for nursing, and have made some gains there, transition as well. As far as the psychiatry goes, it was, and why we do telehealth, it was actually easier for us to recruit and find psychiatry services remotely than it was for us to find people who are willing to come into the site physically.
Thank you very much. Leslie Goldman in healthcare. I was a little surprised at 10,000 pills a day. That's a lot of medicine being moved through the system. And I'm wondering, it seems like a great opportunity for error, not just because I worked in the medical system, so I get it. And I'm just wondering what processes you have for dispensing and preventing error.
That's
And then once error happens, how do you handle it? Because it's inevitable.
So we have an electronic health record that we follow for medication dispensing. We ordered medications through a vendor called Diamond when they come in that we, count and account for. When the incarcerated individuals come up for their medications at the window, we do, name, date of birth. All incarcerated have a wristband that we check that with. If they don't have their wristband, they have to go back and get it.
So they come to you,
They
so
come
you're
to
not
us.
going to them, so that's one step.
We would go to them if they were in a custody situation that required us to go to them because they're not allowed to leave the area they're in, or if there is a lockdown in the system and we have to go unit to unit. But otherwise, they come to us. So using the 5-6 rights of medication is how nurses would go through that process, ensuring that they have the correct med, having the correct person in front of them before they distribute it. We do have med errors. I mean, as you said, it's inevitable with 10,000 pills being passed a day. We have with WellPass what's called a critical event process. So when a med error happens, and actually any kind of critical event that happens goes through this process. So if somebody's sent to the ER, if an incarcerated individual injury, if there's a med error, any kind of event like that, it goes through this process that goes straight to our lead CQI people in WellPath at the corporate level who do a lot of reviewing of our charts and such. But it also comes to me, it comes to our regional director of nursing, and our medical director as well. So when a med error occurs, once the error is discovered, they have to notify the provider who's there on site. If it's off hours, then they would notify via on-call the provider on site or whoever is covering statewide. If additional monitoring is necessary, we would bring that patient into an area closer to medical if there's no infirmary. So usually booking is right off of medical. They might stay in booking for the night so that we can monitor more closely, or they would be in the infirmary so we can monitor more closely. After they've, been deemed safe to go back to their housing unit, they would go back. I notify Max and their team when a med error occurs that requires further monitoring so that they're aware. The on-site DOC is also aware. Once we get that med error in, we do a root cause analysis of sorts to figure out the reason why that error occurred. Sometimes it is, 5 rights weren't followed. Sometimes, we realize that maybe there's rushing at the window. So we know that we have to slow the process down. Sometimes it's directly related to pharmacy and how they distribute the meds. So we would go through that root cause analysis. We would have education with the nurse involved, for sure. And we would document that education plan. We would also take that as not an example and point out the nurse, but use it probably as an educational moment in a staff meeting or whatever to say, hey, this situation occurred. These are some things we learned from it to, keep your, to have a learning lesson from it.
So how many med errors do you have a month?
Oh, gosh.
You can get back to us.
Yeah.
Yeah.
That's a number you don't want to.
Yeah, I'm sure you don't have it on your head. Med errors are a result of culture or reporting of med errors. Many don't, get hidden because people are afraid of consequences.
Yep.
I don't know what your system's like, and I know we want to move on, but that's a concern.
Yeah.
Yeah.
We take an educational approach first and foremost.
And when you do that breakdown, how many med errors in a month? it might be good to look at which facilities, break it down by.
Yeah, we
facilities.
get that data through that system, that tracking system. It can break it down by facility, time of day, that kind of stuff.
And I think that's just a good reminder that this is, as someone said, I think as Max said earlier, this is a acute population. They have high healthcare needs. So. All right, we're gonna keep asking questions and may not get to Kelly. Wayne?
I'd like to flip the script a little bit. So we're giving almost 10 pills a day per every inmate that we have in prison. And it's very convenient to get medical to go and see someone. Like for me, if I have to drive to Burlington or St. Albans, you know, I don't go very often. So it's very convenient to get the services that are being provided. And it's costing us a good bit north of $2,000 a month per patient for care. So of all these people coming in, and I have an aunt, she died some years ago. She was 97 when she died. She was a hypochondriac for her whole life, and what she was doing, she'd go into doctors to get attention. And you can understand, I could see that in prison, you know, you're bored. How much, you know, might you go and seek services because you're bored rather than having a legitimate issue? So do you have any controls on that in any way so that, you know, we're not being taken advantage of?
I mean, our providers are certified educated providers, so they do have, you know, autonomy to prescribe how they choose. But they do know the population that they're working with. And know people, especially those who have been in the system for a while who are, you know, are coming back and back and back to medical. So I would say that they're not prescribing for the sake of prescribing.
You understand my concern?
Yes.
And I just want to reiterate what Jessica just said. I mean, they are licensed healthcare professionals that have to follow the rules of Vermont.
So it was the one my aunt went to for years and years.
Tristan Roberts. A couple of related questions about medically assisted treatment. Are inmates typically being prescribed Subutex or Suboxone?
They're on the monotherapy, so Subutex.
And is there a reason for that?
Cost currently, but we have been exploring the other option.
My concern would be that that's not as effective in helping people avoid, they can get high on other narcotics with Subutex. And we know a lot of people are
Yeah, Tristan, we need you to speak up.
Sorry. So Subutex, you know, you can still get high on other narcotics with that. So there's a concern about it's less effective.
Still can't hear you.
Yeah,
It's a big room. Okay.
yeah, speak up. If you have to stand up, speak for it.
I'll just go with my next question. Thank you.
All right, Tristan.
Thank you for the encouragement. Do you provide, you know, part of MAT standard of care, I believe, is counseling and recovery support. Does WellPath provide that?
Yes.
And to what extent?
We have MAT case managers at every facility. They see the patients under medication assisted treatment one-on-one, and they do groups just based on guidelines and curriculum that has been put forth by the Health and Wellness Department of Vermont DOC.
Can you talk about the frequency of those group supports or?
It really depends on, it does depend on space at the facility and what's allotted to them, but we do try to make sure that there are at least weekly groups happening at every site.
Thank you.
Brian Sheena, who is on Zoom, so.
Thank you. Does WellPath have any mechanism to work with community-based providers to continue care when someone becomes incarcerated? For example, if somebody has a long-standing relationship with a psychotherapist and they become incarcerated, is there any way for the person to continue their work with their existing provider?
No, no. But
Thank
we
you.
can, based on if we get, an ROI from that individual, we can touch base with that provider, to have their medical records and understand their treatment plan.
You good, Brian?
Yeah, but it sounds like the person can't continue the therapeutic relationship with a provider who's already working for them. They would have to kind of hand their record over to someone else to try to do that treatment.
Is that a DOC or a WellPath requirement?
That's, it's based on insurance, isn't it?
Sure. Oh, right, because we can't do Medicaid or Medicare, right? Okay, thank you. Gina?
Yeah, but WellPath could pay the person. I mean, WellPath could pay the person. The provider might not be able to bill the existing insurance, but anyway, you answered the question, so thank you. I want to make space for others. Thank you.
Thanks, Brian. Go ahead, Gina.
Yeah, so Jean Galfetti, representative, thank you. And I'm just trying to drill down on the 10,000 pills a day.
Can't hear you.
I'm just trying to drill down on the 10,000 pills per day. What percentage is that doses per day or actual pills? You know, I mean, it's kind of an ambiguous term. And then, so that's not including MAT
No, that's
doses.
included.
So those are sublingual films. So I just wanted to be
We don't do
clear.
films.
You don't do the films, so all your
No.
Subutex is based on pills. And to, kind of dovetail on that, what are the controls that you have in place so that medication isn't being diverted?
Well, diversion is really the security side. So there is an officer at the window, who will do mouth checks on individuals. Meds that are able to be crushed, we will crush and put into applesauce or water, depending on what the incarcerated individual prefers. All of our MAT meds are crushed, and there is quite an extensive for MAT. Our MAT lines are separated from our general medication line, so that's its own medication line. The medication is crushed, the individual receives it, and then they sit for 10 to 15 minutes to allow dissolving. And there is a correctional officer who is watching that process during that time. So it's an observed
Okay.
timeframe of ensuring that it melts.
And okay, so out of the 10,000 doses per day or pills, however we're slicing that, what percentage of that would you say is MAT doses versus just other medical conditions?
I didn't see the numbers today, but we do have about 600 individuals on that.
Okay, so that accounts for that. And my last question is, if somebody's on a medication that's multiple times a day, what's the control if they forget to come to the window?
If they forget to come to the window, or if they forget to come to the window, if they come later, we will give them their meds. If they refuse to come to the window, then we have them sign a refusal.
Right, but I'm saying more for somebody that it slipped their mind. Is there some sort of oversight in the computer system that says, he takes blood pressure medication 3 times a day and he missed one of his doses simply because he forgot about it?
Right. We do have a system in our electronic health record that
It'll
allows
flag it or
us to
something.
flag when somebody's missed 3 doses of a
Okay.
medication.
Thank you.
All right, so we have Topper and Chip, and then we're gonna have to call it a day.
When I'm in prison, when I get out, and I've served my sentence, what's the process to make sure that there's a smooth transition from inside to outside?
Yep.
In terms of the prescriptions I need and so on.
So we do have, hopefully you're somebody who's sentenced and we know when you're leaving.
Yeah, I'm not talking about when a judge says,
Right. So if we know you're leaving, it's quite easy, actually. We would call providers in the community and set you up with appointments. For your meds, we would provide, so we tell our pharmacy Diamond that you're leaving and they send prescriptions to your preferred pharmacy for you to pick up. We would provide 30 days of medication. Unless it's a MAP med, then we would provide to your next appointment.
I wish it was working out that way.
It was only that easy, right?
If it only. Chip?
So if I'm going to take up the tail end here, I'm going to be a little rough on you. I'm sorry to say, but to pick up on what Representative Casey had started about, there is certainly skepticism around this table and in our legislative body about private for-profit prisons and private for-profit healthcare. And with some research, we discovered that WellPath is a subsidiary of a larger private equity company whose sole motivation is to make a profit. And you may or may not be aware of the letter that was drafted by a number of Massachusetts senators and signed on by 2 of our congressional delegation regarding some of the investigations that they have done regarding your organization. And I'll read from one paragraph that struck me and really disturbed me. And this is, while WellPath asserts that its cost-cutting measures do not compromise quality of services. Extensive evidence suggests otherwise. Nationwide, the privatization of prison health care has been associated with instances of reduced quality of care, higher death rates, and less transparency. The more recent trend toward private equity firms such as HIG Capital purchasing prison healthcare providers, along with food, commissary, and telecommunication providers, has supercharged the profit incentive to compromise service quality. I found that really disturbing. And, from everything else that you read about this, it certainly seems to have merit because a lot of these senators put a lot of time and effort into investigating this. So I guess I would ask you to comment on that, maybe, if you choose to. I mean, I understand its difficulty, and it's more of a comment or a statement than a question, but I just find it really disturbing. I mean, I did prisoners' rights many years ago, and certainly healthcare, when Vermont was providing their own, was a subject of considerable complaints from inmates. But all throughout these articles, it just carries on about various states that have gained judgments and filed lawsuits against WellPath for inadequacy of care, unlawful use of restraints and medical subduing by medical means, and it just doesn't sit well with me, I have to say. And I'm sorry to lay that on you, but you're sitting in the hot seat, as they say.
Oh, yeah. I can't speak to anything that's happened with WellPath in any other state. I know WellPath in Vermont. And we are those who are providing direct care to the incarcerated individuals in Vermont are Vermonters. The nurse at the Medline is not thinking about, cost savings. She's thinking about the patient in front of her. And I can say that the regional office in Vermont for WellPath, we advocate for healthcare to be what Vermont wants, what Vermont requires, what Vermont needs for our individuals. We believe in a community standard of care. And that is something that we will continue to advocate for, regardless of whose name we're working for.
Okay, as oversight, we'll be watching. I have to tell you. Thank you. Thank you for your answer.
Thank you, Jessica. I just want to say thank you to you and all the nurses and medical staff who are working every day to support this population. So thank you. We know it's not easy.
Thank you. Appreciate it.
Thank you.
Yep, we're done for now.
We're
On
gonna
this-
talk how to move forward.